Hello, and welcome to Wellbeing. I'm Graham Wilson. Today we're exploring a sobering new report from the George Institute for Global Health in partnership with the Liptember Foundation, Australia's leading organisation dedicated to advancing women's mental health. The study, Beyond the Surface 2024, reveals the rates of poor mental health among Australian women remain alarmingly high. More than half report symptoms of depression, and nearly as many struggle with anxiety. For younger women, pressures around body image have climbed sharply, while Indigenous women are experiencing disproportionately high levels of PTSD. These findings highlight not only the personal toll of poor mental health, but also the systemic barriers that prevent many women from getting the care they need, whether that's the cost of treatment, stigma, or a healthcare system that isn't always designed with women in mind. To help us unpack this, I'm joined by Professor Bronwyn Graham, lead researcher and mental health expert at the George Institute for Global Health, where she is director of the Centre for Sex and Gender Equity in Health and Medicine, and a professor in the School of Psychology at the University of New South Wales, Sydney. Bronwyn, thanks for joining us on the program today.
Thanks very much, Graham. Pleasure to be here.
How did you get into this specific field? Can you just give us a thumbnail sketch of your career thus far?
Absolutely. So I studied psychology as an undergraduate student and became fascinated with the way that the brain regulates emotions. And so I went on to do a PhD looking at how the brain regulates emotions, and at the same time trained to be a clinical psychologist. And so my career over that time has led me to understand that there are large sex and gender differences in terms of how mental illness presents and the burden of mental illness. And so I've started to look at the female-specific factors that influence mental health, with that understanding that female-specific physiological factors influence the brain and its ability to regulate emotions.
And I read somewhere that you've said that the healthcare industry, if we can call it that, is mainly about men, for men, because it's been designed by men perhaps over the years, yeah?
Yeah, look, I think that the healthcare system, by and large, is gender neutral. And by what I mean by that is that it fails to take sex and gender into account because it assumes that there are no real differences between men and women apart from those related to reproduction. But underneath that assumption is a bias in terms of the research that leads to the evidence-based healthcare that we provide. And we do know that there has been a long-standing male bias in the research that is conducted, where we do tend to conduct research mostly in males. That's certainly the case in the preclinical literature. But even in clinical trials, women are underrepresented, including in clinical trials for psychiatry. And that has a long-standing history. Previously, women were excluded from clinical research due to concerns that we may have harmful effects on people of reproductive age. But unfortunately, what that means is that our evidence base is more tailored to the male body than to the female body. And that, coupled with the assumption that health and disease progresses essentially in the same way in males and females, has meant that we're operating in a healthcare system that actually doesn't serve anybody particularly well, because sex and gender do influence our health. And by tending to those factors, we can really improve the system for both men and women and indeed gender diverse people.
So Beyond the Surface, and you're revisiting that again this year, aren't you, under an extended title. Was there one before 2024 as well?
Yes, so this research has been conducted by the Liptember Foundation since 2022.
Okay.
And it's the largest survey of Australian women's mental health, and it has been ongoing since that time. And in the most recent survey, we at the George Institute have collaborated with the Liptember Foundation to co-produce that report.
So what was the driving force behind getting the research commissioned?
We've known for a really long time that the burden of many different kinds of mental illness, but particularly anxiety and depression, which are the most common forms of mental illness, are greater in women than men. And we see that pattern really across the lifespan. But as I've said, the healthcare system and the vast majority of research does operate on this assumption that sex and gender don't influence healthcare outcomes. And so the Liptember Foundation has wanted to address this by hearing from Australian women what their experiences with mental illness have been. What are the barriers to accessing help? So that we can start to understand how we need to change the healthcare system so that it is tailored to women's specific needs.
One of the results you discovered was that more than half of the women surveyed reported depression and nearly as many anxiety. What went through your mind when you saw a statistic like that?
Well, unfortunately, it's not that surprising because those rates are similar to the rates that women have been reporting since the inception of the survey in 2022, and they have remained unchanged since that time. We note that a quarter of the 7,000 women surveyed are reporting severe psychological distress. Again, not surprising. Anxiety is actually the leading cause of burden in women across the lifespan. It exceeds even that of cardiovascular disease, which is women's biggest killer. It may be surprising to the general public, though, because I don't think that mental illness, the burden of mental illness, is appreciated, despite the fact that I think the stigma surrounding mental illness has substantially reduced over recent years. I still don't think that we appreciate that the burden of those very common mental health conditions is quite so high in women.
How do the figures compare with what you and your colleagues have observed in recent years? Have they stabilised or are they going up because of the pressures of modern life?
The figures bounce around from year to year, but by and large, they are relatively stable. And the top 5 most prevalent mental health conditions that women are reporting experience have been largely consistent, with depression and anxiety and body image issues being the most common. And I think what is concerning about that is that even though I don't think we have enough investment in mental illness, we are seeing investments in mental illness. We are seeing a reduction in that stigma, and yet we are not seeing a corresponding decline in prevalence rates. And to me, that says that we have a healthcare system that is, barely sort of stemming the bleeding.
We'll get to the healthcare system and what's needed. Behind the statistics, of course, are real women with real lives. And there are a myriad of things going on that are playing into this. How are challenges like low self-esteem, financial stress, sleep deprivation perhaps, interlinked and affecting women's mental health?
Well, the report is revealing that these are the sorts of factors that women are reporting are the strongest triggers for poor mental health. And these are factors that, in some respects we see across the board for people of all sexes and genders. Stress is one of the most common precipitants of poor mental illness. But of course, with women, we understand that many of the stresses that they are facing are gendered in nature. So they are reporting the burdens of caregiving, particularly in those middle life years where the caregiving is often directed towards younger children as well as aging parents, and is also at a point where women may be at transitions within their own careers. So women are reporting that those just daily pressures of living are really mounting, that they're not getting the support that they need, and that is leading to triggers for mental illness. The financial stresses themselves are a pressure for mental illness, but are also a key reason that women are reporting to not seek help. It's a key barrier to seeking help, that the cost of accessing psychological treatment is too high.
Okay. Were there any particular stories that come through in the statistics, or don't you get to that kind of detail?
We do collect data from women that allows them to explain to us what are their specific situations that allow us to get an insight into their lives. And I think for us, one of the striking patterns of results was that we were finding that this link between women's experiences with medical conditions, non-psychiatric medical conditions, was actually presenting as a key issue for their mental health. So we found that women who experienced female-specific medical conditions like endometriosis or polycystic ovarian syndrome were reporting higher rates of mental distress. And then when we heard about their anecdotal reports, they are reporting that often this is coupled with delayed diagnoses, misdiagnoses, or feelings of medical misogyny within the healthcare system that is leading to poor mental health.
My guest today is Professor Bronwyn Graham, lead researcher and mental health expert at the George Institute for Global Health, where she's the director of the Centre for Sex and Gender Equity in Health and Medicine, and a professor in the School of Psychology at the University of New South Wales, Sydney. Bronwyn, let's get to the barriers then in support. There's obviously a need. Why are women not getting the support they need?
So women are reporting multiple barriers to seeking help, and chief amongst those are feelings that their mental health conditions are not serious enough to warrant seeking help. So we're seeing that low self-esteem and low self-worth coming into it, a belief that they should be able to manage their mental health on their own. But also financial pressures. It is simply too expensive. More than 1 in 3 women reported that they could not afford to seek help even if they wanted to.
Okay. It's long been known that women are better at seeking help than men. Maybe that's not true anymore.
Yeah, I think that here is one of those interesting gender-specific factors, and one of the reasons why we really need to look at mental health through a gendered lens, because I think I agree with you that there is this idea that women are better at seeking help. But I think that both men and women face these barriers to seeking help for different reasons. With men, the reasons tend to be related to dominant forms of masculinity, a heightened sense of stigma associated with mental illness. And so now we're seeing these great investments through places like Movember that are really helping men in reducing that stigma and encouraging them to come forth. With women, it seems to be that they're also not seeking help, but for different reasons. Stigma isn't as much of an issue, but it's that sense of self-worth, or rather the low sense of self-worth, that is preventing some women from coming forward, where they don't believe that they deserve to get the help that they need, that their problems are not sufficient enough to receive that treatment. And, this is actually something that we see outside of mental illness as well, where one of the reasons where we see a higher rate of death following stroke in women is that they will delay calling an ambulance because they don't want to burden an already overburdened health system. So it's different reasons, but same outcome. It's
the stoic, isn't it? Grin and bear it. It'll be fine. We'll get over it.
Exactly. And I think there we see that intersecting factor of the caregiving role, that women are caring for many people within their family and outside of their family, and that means that their position on that caregiving list gets pushed down to last.
Do the barriers differ between urban, rural, or Indigenous communities?
So by and large, we're seeing similar barriers, but of course, in rural areas, and here you also see an intersecting factor with Indigenous communities, there is a lack of access to sufficient healthcare. So telehealth has helped somewhat with that, but we still have, of course, reduced resources to service mental health needs within those rural communities.
Yeah, you touched on also the stigma. How much does that play a role still with women seeking help?
Well, it certainly still plays a role. And I think that we're seeing that role of stigma particularly play out around different phases of life. So we see our data supports this, and this fits with the broader literature, that there are particular life phases for women that carry a higher risk of mental illness, like pregnancy or perimenopause, or a lot of women experience changes in psychiatric symptoms across the menstrual cycle. And the stigma associated with those phases of life and needing support at those phases of life is disincentivizing women to come forward.
The report, of course, doesn't just highlight the problems, it also points towards solutions. What does genuine gender-responsive care look like in practice?
Well, really, it starts with the research, right? So we really desperately in Australia need to change the way that research is conducted such that sex and gender are taken into account at every stage of the research pipeline, from the questions that are being asked to the outcome measures that are being assessed to who is being included in the research. We can't know what different sexes and genders require if we're not including both sexes and different genders in our data and disaggregating our data according to sexes so that we can pick up those differences. But then, of course, the research on its own is not going to be sufficient if that's not translated through to the education system. And right now, we are teaching our health professionals, not just psychologists, but across the board, that, as I said, aside from reproduction, there's no real differences between the sexes and genders when it comes to their healthcare needs. And so until sex and gender differences in health and illness are included as a national competency across tertiary curricula, we won't see changes, that the implicit message will still be that these are factors that we don't need to attend. So we have to educate our healthcare professionals that these differences do exist and what they can do about them. And then when it comes to the healthcare services themselves, we need to be thinking creatively about how we can leverage existing resources. We know that points of hormonal transition across a woman's lifespan are key areas for risk. And we're seeing investment in women's health with the introduction of perimenopause clinics and endometriosis clinics. As a healthcare system, we need to start recognising that these diagnoses don't operate in a bubble and that mental illness is often highly comorbid with these so-called women's health issues. Those services need to be adequately resourced to be able to assess for mental illness and to treat mental illness.
So you're talking about integrating mental health support with routine healthcare.
Absolutely. One of the striking findings that we observed in this year's report was that despite the fact that a third of women during pregnancy were experiencing perinatal anxiety, only 1 in 5 of those women knew where to go to access help. Now, this is remarkable to me because having been through 2 pregnancies of my own, I know how frequently you are in contact with the healthcare system throughout pregnancy and postpartum. And so the fact that 1 in 5 women did not know where to go to access help says to me that mental illness is not routinely incorporated into these assessments. And we know that now in the postpartum assessments that postnatal depression is screened as a standardizer, but we're not routinely screening for perinatal anxiety, despite that being even more common than postpartum depression. So it's a real missed opportunity that at the exact times when women are having their most frequent contact with the healthcare systems, we're not putting in place screening assessments that would allow us to pick up on these issues and address them before they become really big problems.
And should this change happen at the training level for doctors?
It absolutely needs to happen at the training level for doctors. I think, unfortunately, the way that the medical system works is that people routinely become specialists in their own areas, and mental illness is one of those things that is put down to, well, this is dealt with by mental health care specialists. But I think it's very clear that all health professionals are going to be encountering people who are experiencing comorbid mental health issues, particularly those who are working in women's health, in perinatal health, in perimenopausal health, and in all areas of sexual and reproductive health. And so we really need to make sure that those professionals are being trained in the likelihood of mental health conditions emerging or becoming more severe during these phases of life, so that women can receive the support that they need, or at least be picked up that they require this help, so that they can be directed to the most appropriate services.
And at the heart of it is accessibility to a doctor who knows what's going on with mental health. Does telehealth have a role to play?
Telehealth does have a role to play. And as I said before, it certainly does open up the treatment options for people who are living in remote and rural areas. I think the broader issue is that the Medicare rebates for mental health are tied, as they should be, to regulated health practitioners. And right now, we do not have a psychologist or a psychiatrist workforce that is large enough to deal with the magnitude of the number of people who require help. And that is not going to change. Across the world, we are seeing consistent rising rates of mental illness, and this is happening faster than we can resource the existing workforce to deal with this issue. So ideally, we would like to see that Medicare rebated sessions be reverted back to the 20 rebatable sessions a year, but that's only going to work if we have a workforce that can accommodate that. And so really we need to be thinking about what can we do to open up the regulation of other healthcare professionals, mental health care professionals, so that they can access those rebates and service those needs.
Just in our closing minutes, Bronwyn, can we talk about the broader social impact of addressing these problems? Specifically, give women better access to mental health care. What is the broader impact for society from that?
When we have mentally well women, we have a thriving society. And I think that is evident in the caregiving roles that women provide. Women are looking after our society. We need to look after women. It increases productivity. It boosts the economy. At the individual level, of course, it leads to a high quality of life. There is no argument that goes against the need to be supporting women. And the same applies for men. But the way that we do that is to ensure that everybody is getting appropriate health care that is tailored according to their needs, and sex and gender are very important individual difference factors that need to be attended to in providing appropriate care.
Is there anything that ordinary Australians can do in families, workplaces and communities to better support women with their mental health?
I think having these conversations around the dinner table is always the best place to start. A lot of the topics and the phases of life that we know are linked with poorer mental health in women are often topics that are taboo. It's only recently that we're starting to see conversations about perimenopause enter, the standard sort of social awareness. I think that there's a lot of pressure on women around the perinatal period to look like they have it all together, when we know that it's a period of high stress for everyone, regardless of how happy they may be at that time. And so I think going into those life transitions with an assumption that this is going to be a period where we need to wrap around and provide support for women is essential. And that really starts with just having those open and honest conversations at the dinner table.
And finally, if you had the ear of government today, what's the one change you'd ask them to prioritise?
I think that the government needs to have a role in ensuring that sex and gender become part of the accreditation and registration standards for all health professionals by changing the national law so that the regulatory bodies that approve the university programs that train our future health professionals mean that sex and gender awareness is integrated into that training right from the get-go. And that is how we create a workforce that provides better quality and better evidence-based care for everyone.
Thank you, Professor Graham. Thanks for coming on the program today.
Thanks, Graham.
I've been speaking to Professor Bronwyn Graham, lead researcher and mental health expert at the George Institute for Global Health, where she's director for the Centre for Sex and Gender Equity in Health and Medicine, and a professor in the School of Psychology at the University of New South Wales. The study we were discussing was Beyond the Surface 2024. The research is a reminder that poor mental health isn't just an individual struggle, but a widespread social challenge that needs urgent attention. Thanks for listening. I'm Graham Wilson, and all of us at Wellbeing wish you well.